Thanks for the introduction, and I'm glad to be here to share some data of the neuroventilatory efficiency and weaning. Why weaning is so important to critically ill patients? And we all know weaning tends to be delayed, and if appropriate weaning always leads to unnecessary discomfort and increased risk of complications. And we know, as we know, about 40 to 50% of the duration of mechanical ventilation was spent in the weaning process. And if prolonged mechanical ventilation happened in 6% of all ventilated patients, and also associated with pretty high mortality. So with respect to the time point of weaning, and as demonstrated before, almost half of the patients with a self-distribution during the weaning period do not require reintroduction. And if we go through the weaning process, there are 6 continuous steps. And the first one, we treatment of the acute respiratory failure, and then we suspicion, and that means at which point we start to suspect our patients may be ready to start the weaning process. And then we assessing the readiness to wean. If they pass, we do the spontaneous breathing trial, and if they passed, following by the patient was extubated. And unfortunately, almost 20% of our patients fall in the 6th step, the reintroduction, and that's meaning weaning failed. The weaning failure is a complex issue because a lot of reasons can cause it. It includes airway and lung dysfunction, brain dysfunction, cardiac dysfunction, diaphragm dysfunction, and so on. And about 60% of weaning failure is caused by the respiratory dysfunction, and that means weaning failure is at least partly due to the respiratory load exceeding the capacity of the respiratory muscles. So how to evaluate the balance of the respiratory load and the capacity of the respiratory muscles during weaning at the bedside? Maybe neuroventilatory efficiency and neuromechanical efficiency should be the good candidates. And as presented before, the neuroventilatory efficiency is the ratio of tidal volume over the EDI, and it's expressed the ability to generate volume normalized to the neural drive. And for the neuromechanical efficiency, it's measured during inspiratory occlusion, and it's an index, it's a rate of a change of airway pressure over the EDI. And NME provides an estimate of respiratory pressure generation normalized to the neuroinspiratory effort. So the aim of our study was to examine whether a patient who failed the extubution when compared to the successful patients have increased EDI, which reflecting a higher neurorespiratory drive, and may have lower NME as an indication of more pronounced respiratory muscle weakness, and may have a reduction in NVE due to a combination of the weakness and increased load. So we enrolled the patients who was controlled mechanical ventilation for more than 24 hours and do not fulfill the study exclusion criteria. And after enrolled, the patient was switched to a SOI ventilator, and the EDI nasogastric tube was put in instead of the normal feeding tube, and the patient was ventilated with pressure support mode or SME plus pressure support mode before the protocol start. And here is our protocol, and patients were screened, and if they passed the screen, the spontaneous breathing trial was performed. First, we start with the pressure support ventilation of 10 centimeters of water, and as a baseline with 5 PEEP. And then the spontaneous breathing trial was performed by CPAP 5 for 30 minutes. So you see here, and during the 30 minutes of spontaneous breathing trial, at the first minute, 5, 10, 15, and 30 minutes, we do an inspiratory occlusion to measure the neuromechanical efficiency. And the patients who reached the criteria for failed SBT were resumed to mechanical ventilation, and we'll screen the next morning. And patients who were able to tolerate the 30 minutes of spontaneous breathing without reaching the exclusion criteria were extributed. And here, extribution failure was defined by if the patient failed the spontaneous breathing trial or required an IV after extribution, or reintributed, or deceded within 48 hours post-extribution. And if the patient completed the SBT and remained extribution for more than 48 hours, it was considered as a successful weaning. So here is the flow chart of the study. Totally, we screened 404 patients, and include patients number was 55, and 35 patients were successfully extribution, and 17 patients failed, which include 6 patients who failed the spontaneous breathing trial, and 5 patients who need an IV, and 4 patients who need reintribution, and 2 decede. So here goes the patient's directions. And as we see here, patients in the failure group was much older than the patients in the successful group. And the mean age was 76 or 65. Also, if we see the cause of the respiratory failure, and we see there are quite pretty high percent of AE COPD patients in our failure group. It's 59, about 59. And here goes the mean result. And as we see, here is the different time point during the trial, and it's PSV10, and this was the time of the spontaneous breathing trial, T1 to T10. And as we see, the EADI was around, the peak EADI was around 10 at the pressure support ventilation, and was no difference between the failure and successful group. And immediately after we switched to CPAP 5, the EDI increased immediately in both groups, and METRA reached a plateau quickly. And we can see here the EDI in the failure group was almost twice than that in the successful group. And NME has the same style, and we see the failure group was lower and the successful was higher. And to NVE, at pressure support, switch to the CPAP, and they decrease immediately in both groups. And at each time point during the spontaneous breathing, the NVE value in the successful group was much higher than in the failure group. So here is the breathing pattern, and we see the tidal volume, the same style. Immediately decrease after switch to CPAP, and then meet a plateau, and the tidal volume in the successful group was higher in the failure group. And also the VE and the frequent, as respect to the respiratory rate, and we see the respiratory rate in the failure group was much higher than in the tendency to be higher in the successful group, and reached the statistical significance at T1 and T5. And with respect to the Tobin index, it also has the same style, and after switch to CPAP from the PSV, and we can see here the immediate increase of the Tobin index, and during the spontaneous breathing trial, in the failure group, the value was much higher than in successful groups. So if we check the blood gas, and we see there was no difference of pH and pF ratio between the success and the failure groups, but the PaCO2 and bicarbonate was much higher in the failure group. And the last one is the distribution predictability. And in my opinion, there was not a single reliable index which can predict weaning failure or success. However, we calculated the area and the ROC curves of these parameters to detect how good these parameters for separating the successful or failed distribution. And as we see, the area under the ROC curves for the neuroventilatory efficiency was 0.84, and for other parameters, EDI, NME, and Tobin index was around 0.7, about 0.7. And if we use a threshold of 24.1, we get a sensitivity of 0.69 and a specificity of 0.88 for the neuroventilatory efficiency for predicting the weaning success. So in conclusion, critical ill patients who fail weaning are characterized by increased neurorespiratory drive and impaired ability to convert neuromuscular activity into tidal ventilation. This is at least in part due to inspiratory muscle weakness. And the measurement of neuroventilatory efficiency can be valuable in clinical decision making about distribution readiness. Okay, thank you for your attention.
Okay.